So first, kind of changes in nomenclature. So this was just released over the weekend. So we are now sort of encompassing all of fatty liver disease as steatotic liver disease. So this is going to be the big overarching term that encompasses several different disorders. So the term that's going to replace MASLD is metabolic dysfunction associated steatotic liver disease. So I'm very excited to tell patients about this mouthful diagnosis that they will now have. So the diagnostic criteria for this will be that they either have steatosis on imaging or histology, and then they have one out of the 5 following cardiometabolic criteria. So either they have obesity defined as BMI or elevated waist circumference, some type of insulin resistance, either defined as fasting serum glucose over 100, elevated A1C, type 2 diabetes, or on diabetic treatment. They have hypertension or are on antihypertensives. They have triglycerides over 150 or already on lipid-lowering treatment, or they have low LDLs or are already on lipid-lowering treatment. So just to sort of backtrack a little bit, just to sort of redefine all of our terms, so this will now be MASLD, so steatosis plus at least one cardiometabolic risk factor. And then so there is still the distinction between patients who have just steatosis and then those that have steatohepatitis. So what was previously defined as NASH will now be MASH, which is metabolic dysfunction associated steatohepatitis. So for lots of reasons, it was really important to keep steatohepatitis as a clinical criteria, not only for clinical trial purposes, but of course we know that patients with steatohepatitis are more likely to progress to advanced fibrosis and cirrhosis. So for lots of reasons, important to kind of still have that distinction. So as you know, patients who have just simple steatosis are at much less likely risk to progress, so less than 4% with simple steatosis will progress to cirrhosis. Whereas when we're looking at patients with steatohepatitis, that's patients who not only have fat in the liver, but also inflammation, signs of hepatocyte cell death. About 20% of those will progress to cirrhosis, and of course, those are the patients that we worry the most about. So our second category now will now be the combined MASLD plus increased alcohol intake, which will be called MASLD. So we do see a lot of combination overlap with patients who have metabolic disease, but also drink excessive alcohol. And so previously we haven't really had a term for this, so it's nice that it now has a defined diagnosis. So this will be patients who meet the criteria for MASLD and then either have high average alcohol weekly intakes or average daily intakes as defined here. So this will likely be a spectrum. So there may be patients who have more metabolic criteria, but of course some excess alcohol intake, and then it could be potentially alcohol predominant with less metabolic features. So I think there will be lots of ways to study this moving forward, but just a new term to define the combination. So next, there will be strictly alcohol-associated liver disease. Of course, this has already existed, but will now kind of be under this umbrella term of steatotic liver disease. And then next is specific etiology, steatotic liver disease. So this will include things such as drug-induced liver diseases, monogenic liver diseases, which are some of the more uncommon genetic disorders like liposomal acid lipase deficiency, Wilson's, and some of the pediatric inborn errors of metabolism. And then miscellaneous may include things such as celiac disease, severe protein calorie malnutrition, things like this. When we're thinking about drug-induced liver injury, of course, these are things that we always look for in the clinic when we're seeing patients. So there are lots of medications that can cause steatosis as well as steatohepatitis and cirrhosis. So anytime we're evaluating patients, we always look for these as potential etiologies in addition to potential metabolic risk factors. And then lastly, there will be cryptogenic liver disease, so patients who have steatosis on imaging and histology for reasons that we cannot explain. So that's sort of the overarching new algorithm. So first will be, does the patient have steatosis? Second question will be, do they have any cardiometabolic criteria? If yes, is there any other causes of steatosis? If not, it will be MASLD. If yes, it could be the combination MASLD or some other potential combination etiology. If there's no, if they don't have any cardiometabolic risk factors and they don't have any other causes for steatosis, it'll be cryptogenic. Or if they do have other causes, then it'll be a specific etiology steatotic liver disease. All right, so that was a mouthful, hopefully, but we do kind of expect this terminology to take over. So next we'll kind of talk about the new screening guidelines. So guidelines have been released across multiple societies, so endocrine, ASLD, as well as now the ADA. And so they all are fairly similar, so we'll review those. Of course, as we think about screening, we always want to think about patients who are at highest risk to have disease that need to be screened. This was a paper from Dr. Harrison several years ago, just looking at the prevalence of, I guess I'll say, MASLD and MASH, to try to start using the new terms, but across different disease etiologies, different metabolic risk factors. So as you can see, kind of starting on the left with obesity, the prevalence of MASH in that group is about 26%. As we look at patients with diabetes, increases to 36%. And then on the far right, looking at patients with metabolic syndrome, and this sort of Dr. Harrison defined high-risk group, which was Hispanic females with obesity and type 2 diabetes, you can see that almost half of those patients have MASH, so at high risk to progress to cirrhosis. So making the diagnosis of MASH will be similar to NASH in that it is, at this time, remains a biopsy-proven diagnosis only. So we can't diagnose it. We can predict that patients may have MASH using other modalities, but a firm diagnosis still remains with liver biopsy. So we know that clinical biochemical imaging measures cannot distinguish the two at this time. So patients have to have steatosis, evidence of inflammation, and evidence of hepatocyte cell death to have MASH. The other things that are really important to know is that liver tests are really not very helpful for this disease. So I think very commonly we see that patients have steatosis on imaging and high liver tests, and then they're given the diagnosis of MASH. And that is a culture we're very much trying to change. We know that lots of patients who have MASH and are at risk for progression have completely normal liver tests. Likewise, we also know that sometimes patients who just have simple steatosis have very high liver tests. And so overall, ALT levels have not been correlated with MASH, fibrosis, or risk of progression. And so we really want to help primary care and endocrine providers move away from using liver tests as a screening and using other assessments, which we'll talk about. So in terms of liver fibrosis, there's 4 stages. So this is, of course, anytime I see a patient with any type of liver disease, MASLD or something else, we always need to know how much scarring and damage is there. So this is how we grade fibrosis. So stage 0 means no scarring and damage in the liver at all. Anybody that has stage 2 is considered clinically significant fibrosis. Stage 3 is advanced fibrosis. Stage 4, cirrhosis. And so these distinctions are very important. And so this is the reason why. So we know that how much fibrosis is in the liver is not only linked to liver-related mortality, but also all-cause mortality. So specifically, when we look at patients with stage 2, 3, and 4 fibrosis, you can see sort of rapidly rising rates of mortality, both liver and all-cause. So when we're thinking about new pharmacologic agents that may come available for MASH in the future, these are the patients that we're really targeting for treatment because they're at the highest risk of adverse liver-related outcomes, but also all-cause mortality. So this is sort of an overview of the endocrine practice guidelines that came out in 2022, but as I mentioned, they kind of parallel what the Liver Society and ADA has released, so we'll just use these figures. So this is sort of the broad overview, and then we'll go into a little bit more detail. So should we be screening for fibrosis in primary care and endocrine clinics? So previously, the last ASLD guidance on NAFLD was released about 5 or so years ago and said that we should not be screening because we didn't have any therapies available. So this is a change. So now it is recommended that patients should be screened if they have obesity, features of the metabolic syndrome, prediabetes or type 2 diabetes, hepatic steatosis incidentally found on imaging, persistently elevated liver test, or the ASLD is now recommending additionally first-degree relatives with cirrhosis related to MASH. So this is new, and again, we're screening for fibrosis, so we're not screening to see if patients have fatty liver. We're taking a population of patients that we presume has fatty liver because of their risk factors, and we're screening to see how much scarring and damage may be in the liver. So then the next question, of course, is how should we be screening? So I mentioned that liver tests are a really poor screening exam for this disease. So what's recommended is that we should be using liver fibrosis prediction calculations such as the FIB4 to assess risk of fibrosis. So what is the FIB4? So fibrosis 4 index is a non-invasive calculation to assess risk of fibrosis. It's very easy to calculate, which is one of the reasons it's been widely chosen and distributed. So it includes age, platelet count, AST, and ALT, so things that are readily available in primary care and endocrine clinics. And so your results can fall into one of 3 categories. So either you can have a low score, which is less than 1.3. That is very good to exclude advanced fibrosis. Patients can also fall into indeterminate category, which is scores between 1.3 and 2.67. Those patients deserve further investigation. And then some patients will fall into the high-risk category, which is scores above 2.67, and those patients are likely to have advanced fibrosis. So what do we do after we calculate the FIB4? So based on their risk category, we'll kind of go through what the next steps look like. So patients who fall into low-risk categories, so those are those FIB4s under 1.3, those patients do not need additional testing, and at this time are recommended to stay in primary care or endocrine clinics with a focus on obesity management and cardiovascular disease prevention. So patients who fall into indeterminate scores, those are the scores between 1.3 and 2.67, it's recommended that additional testing is done. So what's currently being recommended is either if you have access to elastography, this is an imaging assessment of fibrosis, that you can either do imaging assessments or you can do the ELF blood test, which we'll talk about a little bit more in a second. So what is the ELF? So of course we have some folks in the audience that know much more about ELF than I do, but Enhanced Liver Fibrosis Test is a non-invasive blood test. It's a panel of markers that include type 3 procollagen peptide, hyaluronic acid, and tissue inhibitor of metalloproteinase 1. It's very accurate to predict fibrosis in patients with MASLD and has a high negative predictive value in populations with low disease prevalence. So it's really targeted for primary care clinics. I would argue that no clinic in Alabama or the South has a low disease prevalence of MASLD, as we know that probably 30% of the patients we see have it, but still kind of targeted for primary care as opposed to specialty clinics. So as you can see here in the table, patients who have a score under 7.7, that predicts low risk for any fibrosis. And so scores above 7.7, you can see predict moderate severe or cirrhosis. So those, of course, are the patients that we would want to be seeing in the hepatology specialty clinics, would be anyone with a score above 7.7. So the other option, of course, is elastography. So this is an imaging assessment that can either be done with ultrasound or MRI. But we know the reasoning we use this is we know that how stiff the liver is correlates with how much scarring and damage is in the liver. So as we use elastography to measure liver stiffness, that can give us some prediction of where the patient falls on that fibrosis scale. So most often what's used is vibration-controlled transient elastography or FibroScan. This is the most widely available test. It's a point-of-care test. Very easy, can assess both steatosis and fibrosis. It's very accurate to rule out advanced liver disease. So again, recommended for those who have indeterminate FIB4 scores, and if the score falls above 8 kilopascals, that suggests that the patient could have at least clinically significant fibrosis and should see a specialist. So as we kind of look at our secondary tests here, so patients based on their secondary test can then also fall into low, indeterminate, or high-risk categories. So if the liver stiffness is low, less than 8, if the ELF blood test is low, less than 7.7, that patient goes back to their low-risk category and can be safely managed in primary care, again focusing on obesity and cardiovascular disease prevention. If the secondary test is also indeterminate, which does happen sometimes, those patients should go to a specialist. They likely need more advanced imaging or biopsy to clarify their fibrosis stage. And then, of course, anyone falling into a high-risk category, either based on FIB4 or any of the secondary tests, we would, of course, recommend that those patients come to see a specialist. So high-risk categories based on FIB4 scores above 2.67. Those patients do not need any additional testing in the primary care and endocrine setting and should just be referred. And of course, we can decide what is needed at that point. So once they come to us, of course, our jobs are to figure out the correct, whether or not they have MASH, how much fibrosis is present. If there is clinically significant to advanced fibrosis, of course, trying to enroll those patients in clinical trials, in addition to cardiovascular disease prevention. So this is just sort of summary of recommendations for referrals. So indeterminate FIB4 or elevated, then you prompt the liver stiffness or ELF test. If those are above 8 or 7.7 respectively, those patients get referred, and then anyone that falls into the high-risk categories based on any of the testing. And then lastly, we'll just review the management of cardiovascular disease factors. I know Dr. Brill's going to touch on this, so I won't go into much detail here. But the ACE guidelines that came out last year actually have really nice resource for management, so I think that's helpful to go through. Of course, for any patient who has MASLD, we do strongly recommend dietary interventions, and so diet that is most widely recommended and has the best data is the Mediterranean type diet, which really kind of falls in line with this Harvard plate. So it's lots of fruits and vegetables, whole grains, lean meats, unsaturated fats, and low intake of refined carbohydrates. So this is a good resource for patients. So then moving kind of into what can be done in primary care clinics to address the cardiometabolic risk factors. This is sort of just the nice resource that was in the ACE guidelines, so I won't go into it in great detail, but weight management, of course, is very important. So this kind of talks about, besides just telling patients to exercise and eat healthy, what else can we offer them? So of course there are medical treatments available to treat obesity that we should be familiar with. So patients who are at low risk for fibrosis can really receive any of the medical treatment options available. So that's things like phentermine, Qsymia, Contrave, Saxenda, Wegovy, Orlistat. So lots of options in that low risk category. As you move on to patients who have MASH or more significant fibrosis to advanced fibrosis, GLP-1 receptor agonists are currently recommended. So that would be your liraglutide or semaglutide. So diabetes management, I definitely don't want to step on Dr. Brill's toes, but just to know that the guidelines do address diabetes management for MASLD and MASH, and so we know that agents that can reduce liver fat include pioglitazone, GLP-1s, and SGLT2s. So patients at low risk for fibrosis can receive any of those. So far, the data shows good response or efficacy in MASH for pioglitazone and GLP-1, so those would be preferred in anyone who has higher stages of fibrosis. Hypertension management, of course, first line remains ACEs and ARBs. Just to point out, if we did have a lot of primary care people in this audience, that ACEs and ARBs should not be used in decompensated cirrhosis, but otherwise are recommended first line for hypertension management. Next, moving on to dyslipidemia management, I think there's a lot of misinformation about statins not being safe for the liver. Of course, always important to sort of rectify that, and that statins are very safe. They have been shown to be anti-fibrotic, anti-inflammatory, have lots of benefits in liver disease. So we do strongly recommend that patients are on statins if they have an indication to be on statins. The only patients that we would recommend not take statins would be very decompensated patients. We know that those patients are at higher risk of getting rhabdomyolysis, but those would be patients listed for transplant with very advanced liver disease. But otherwise, we highly recommend statins for these patients. So lastly, nomenclature changes are here. So let's start using MASLD and MASH to replace NAFLD and NASH. 2, we do now have screening guidelines in place in patients with obesity and cardiometabolic risk factors to assess risk for fibrosis. And then 3rd, there are really nice guidelines available to help treat these cardiometabolic risk factors in patients with MASLD. And so just know that those resources are available for your patients. And that's all I have for you.